We are now going to discuss some common orthopedic problems for children and on the test. First, we're going to evaluate the child with a limp. The most common cause of limping in children is acute trauma. And so when you're reading the test question, you will hear about the child running, bumping into something, falling, whatever, and then limping. That's too easy. Other causes include neoplasms, infections such as osteomyelitis, arthritis, like septic arthritis, and toxic synovitis. Always look at the age. Remember that trauma is the most common cause, but now look at the age, and we're going to discuss a couple of other causes of limping in children other than trauma, which are age-related. Break it down into birth to 3 years. The most common thing that you should think of there is developmental dysplasia of the hip. 4 to about 12 years of age, think of leg Calvé-Perthes disease. And after 12 years of age, you should be thinking of slipped capital femoral epiphysis. And we're going to go over each one of these. Developmental dysplasia of the hip is a ligamentous laxity. It's a spectrum of disease. It doesn't necessarily mean that the hip is dislocated, although that is the extreme form. It can also be a dislocatable hip. It's more common if there's a family history, and certainly common in the breech presentation. Tests that you need to know, and names of these tests, are the Barlow and Ortolani tests. These are done at the newborn exam to look for dislocatability. So they will describe the Barlows, they will describe the Ortolani. The Barlows is you are going to be holding your hands, your thumbs go on the inner greater trochanter, your fifth finger is basically on the outer trochanter, the lesser trochanter, and you will bring it in, and you will feel, they'll describe a click or a clunk. You're actually feeling the hip, the femoral head sliding into and out of the joint. With the Barlows, it's sliding in. With the Ortolani, it's sliding out. Also the Galeazzi sign. Galeazzi sign shows that when you are examining the legs, because of the dislocation, when you look at the knees on a plane, one knee will be lower than the other because of this dislocated leg or hip. The best test in the newborn, if you have a click or a clunk, is to do an ultrasound. A dynamic ultrasound shows that you are dislocating and relocating the femoral head into the acetabulum. If the child is older than 4 months of age, you can do what are known as frog lateral films. Typically, they'll present you a newborn with a click or clunk. Get the ultrasound. Treatment of the developmental dysplasia of the hip includes containment. Most people will put them in a Pavlik harness. The Pavlik harness looks like a medieval torture device, but it keeps the femoral head located by the acetabulum. It is left on there for all day long, basically, 23 out of the 24 hours. The patient will be followed by an orthopedist. Hopefully you don't need to do casting, but that's another form of treatment. This is a patient that the examiner is doing the Ortolani and the Barlows. Leg Calvé-Perthes, sometimes known as leg Perthes or leg Perthes-Calvé disease, is an avascular necrosis of the femoral head. It can occur after trauma. The femoral head has a very tenuous arterial blood supply, hyperviscosity. A lot of different things can affect supply to the femoral head. Decreased supply of oxygen can lead to leg Perthes. It's more common in males. It usually starts as a painless limp when running. They may have decreased range of motion. With time, they start to limp even with walking, and it becomes painful. Another key point to remember is that hip pathology will refer pain to the knee. So sometimes patients complain of knee pain. Please examine the hip or consider that as part of your differential diagnosis. X-ray films are diagnostic. So you just get plain films, AP and frog leg films, and that shows a flattened femoral head. And the treatment will be basically containment. Some people will try these special braces or stretching exercises. And usually over several years, the patient will improve. And then you can see subsequent films and the femoral head returns to normal. And the last one in the older child is slipped capital femoral epiphysis. This is almost like a break at the epiphysis. It is going to be, especially on the exam, look for an overweight adolescent and then think of associations with hypogonadism. So you should be thinking of LH and FSH. Also think of thyroid problems. Those patients need thyroid screening. And that's going to be the most common presentation that you're going to have. On X-ray, these patients, they describe the ice cream cone or the ice cream ball falling off the cone where the slip is. You can pin them. Here, the arrow signifies where the slipped capital femoral epiphysis is. If you look on this side, this is normal. There's a normal relationship of the neck, femoral neck, and the head. Over here, you can see that it's kind of slipped a little bit, and you can see a more prominent area right here. This is slipped capital femoral epiphysis, and sometimes they need pinning as treatment. But remember hypogonadism and hypothyroidism as associations. Transient synovitis can be mistaken for septic arthritis or even osteomyelitis. Usually, this is following a mild viral infection. We don't see chickenpox that much anymore. It used to be classic after chickenpox, but any other viral infection resolves, and then the patient can start complaining of some pain in the joint. The pain can also be referred to the groin and to the thigh and to the knee. X-rays are normal. It's in bold for a reason. So your first step is going to be to get an X-ray of that affected joint, and it's going to be normal. The SED rate is slightly increased. These patients don't need any further workup. It's probably just a transient synovitis. They're going to get better on their own.